Hi, I'm Helen Bauer, and this is the Heart of Hospice Podcast. The Heart of Hospice Podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode of The Heart of Hospice is being sponsored by Care Boss, the latest book by Jennifer O'Brien. Care Boss is the book that reminds family caregivers that they are the CEO of their loved one's care. Jennifer has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband. Care Boss is written to empower caregivers, but it's more than just a book. It's a workbook and organizational tool as well. Check it out at jenniferaobrien.com.
Welcome back to the second episode in our two-part series featuring psychiatrist, researcher, and author Dr. Harvey Chochinov. Dr. Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at Cancer Care Manitoba Research Institute. He's led a large program of research on dignity within the healthcare setting, which includes the development and study of dignity therapy. His latest book is entitled Dignity in Care, The Human Side of Medicine, and it was published by Oxford University Press. You can find Dr. Chochinov's works at dignityandcare.ca. This episode continues my discussion with Dr. Chochinov, and we covered a lot of ground. Providing dignity to people at the end of life was a major point in our discussion today. According to Dr. Chochinov, and I of course agree 100%, elder speak use by healthcare providers is a problem that needs to be addressed, and he gives some examples of how we can improve in this area. Dr. Chochinov's book, Dignity in Care, The Human Side of Medicine, has been republished in paperback, so you can look for a link in the show notes or visit dignityandcare.ca to purchase a copy for yourself. We've got an amazing episode for you today, so stay with me for the conversation. There's a lot to learn. So let's talk about these folks whose identity and abilities began to drop away through neurodegenerative diseases. So here in the U.S., this is our fastest growing population of Medicare hospice patients, Alzheimer's, dementia, Parkinson's. And of course, it's a huge number in the United States and rising every year. So treating them with dignity and preserving their identity is a little bit of a different game for healthcare providers and for their family caregivers. What would you recommend when it comes to dignity therapy and supporting somebody who's reaching an end-stage process with a neurodegenerative disease?
Yeah, no, you're right in that there's another dimension to that when cognitive acuity begins to decline, because cognitive acuity is something that most of us affiliate with our core sense of self. We have done some work in that lane. I mean, the prominence of the work that we've done, or the majority of work that we have done, has really largely been in the area of patients who maintain some degree of cognitive acuity, to the extent to which some of these interventions that we've introduced still have resonance. But when cognition begins to decline, the question arises, well, does dignity still matter? Does it still make a difference?
Right.
Well, we have done some studies, and there have been some studies of dignity therapy. My colleague Bridget Johnson in Scotland has done studies where they have looked at patients with mild to moderate cognitive decline and done dignity therapy as a co-construction with a family member. And what they found, and what we found, is that if you change the perception of the healthcare provider, then that has an influence on the tone of care. So it changes the way that I see or appreciate that person. And I think, we can ill afford to stop seeing people as people. If we start seeing people as bodies that need to be maintained, then we start treating people, as bodies. And we know, and again, I haven't done this work, but people who, there have been some really interesting studies in patients with moderate to severe dementia. The studies that I'm thinking of have looked at something that is referred to as elder speak. And elder speak is this kind of sort of canned, saccharine kind of way of speaking to people that, again, is generic and rather, and the bottom line, and rather dismissive. So the idea that, everybody is referred to as dearie or honey or sweetie. And, it's a way of sort of, it's kind of like pseudo-affectionate. And it's pseudo-affectionate because, in essence, what it means is that nobody needs to be acknowledged. I don't need to remember your name or acknowledge who you are, because everybody is referred to with that kind of saccharine brush. The studies that have been done on this say that have reported that when you use elder speak, or when elder speak is something that is prominent, then behavioral discontrol becomes more rampant. And if you diminish elder speak or eliminate elder speak, then people settle down. So even when cognition is no longer intact, people are aware of tone and touch, and those are the things that we need to be mindful of. I always remember this anecdote. Years ago, I was presenting, and there was a senior geriatrician who told me about a case where he was asked to see an elderly person, dementia. This was in a VA hospital, and it turned out that this individual that he was referring to had been a fairly high-ranking member of the military. It's not something, he discovered it in his chart when he was doing the review. And one of his interventions, he says, from now on, we will call him by his full military titles. And he settled down. So, there is something about acknowledging people, respect, and continuing to, if you can see and appreciate, who somebody was, who they tried to be, it changes the tone of care. And in our work, care tenor is something that we have introduced into the literature, and it refers to, again, not necessarily what you're doing to and with patients, but the tone of care, and so it's based on. I remember once presenting this to a group of people working in oncology, and one of the nurses said, "Oh, she referred to that as the fragrance of care." You walk in the room, and it's that kind of ineffable quality that you have that just kind of puts people at ease. So tone of care, I would say, is important until the very end of life.
I think that's a good thing for every healthcare provider to remember. So I want to dive into dignity therapy.
Okay.
Using it at the bedside. Tell me what it is and how folks who are actually working with patients with serious illness, how can they utilize dignity therapy?
So, I mean, at this point, dignity therapy is now being on the scene for, it's been like about 20 years, more than 20 years. It's the most studied psychological intervention in palliative care today. There's over 100 articles in the collective medical literature. There's about 12 systematic reviews on dignity therapy. And, all of them collectively essentially say this is a way of enhancing end-of-life experience. I mean, there's variability in studies, so depending on, the people that, the cohort in which it's studied and the outcome measures that it's used. That being said, dignity therapy is based on the idea of generativity and really focuses on issues of legacy. So dignity therapy is a brief intervention where a trained therapist guides a patient through a very specific conversation that allows them to elicit information that they would want as part of their legacy. So it may be critical biographical information that they would want known. It may be particular experiences that they would want remembered. It may be hopes, wishes, or dreams that they would want passed on to particular individuals in their lives, people who will outlive them, things that they've learned. That gives you kind of a flavor of the kinds of things that we elicit in the course of dignity therapy. Those conversations are recorded, they're transcribed, there's an editing protocol, and the document then is returned back to the patient for him or her to give to the people in their lives that matter. That protocol that I've shared with you and dignity therapy now is being done in programs and in countries, around the world. It was designed initially as an end-of-life care intervention, but it's a way of highlighting issues related to personhood. And so even though I might not have predicted it, but the fact is that other areas where personhood is under assault are places where dignity therapy is also being applied. So if you think about, we talked about dementia, personhood is under assault because of cognitive deterioration. Patients with mental illness, dignity therapy is being used. Earlier on in illness, really when people reach what I refer to as kind of a state of existential readiness. So, for example, dignity therapy is being done in non-imminently dying patients who are simply elderly folk. And existential readiness means that people have reached a stage in their life, for whatever one of those reasons, in which reflecting on where they've been, where they are now, and an opportunity to integrate those things in the course of creating a legacy document feels salient to them. Maybe a case example makes it feel more tangible. Recently, I was referred a young woman in her early 30s. She was young, she was in a relatively new marriage, young child, and she was now dying of metastatic breast cancer. It was a horrible case, but she was so keen on doing dignity therapy and really used it as profoundly and as fully as I could have ever imagined, because she used it to thank her parents for all they had done in her life, to thank her siblings, to leave. She said, I know my daughter will not remember me. So she wanted to leave pivotal kind of anecdotes that were so important in her life that shaped who she was, give her certain pieces of wisdom that she might use as guideposts along her life. And then finally, thanking her husband and giving her husband explicit permission to find another love partner, with the proviso that whoever he chose would love her daughter as a mother is meant to love a daughter. So there's a lovely example of how dignity therapy, had such incredible utility, and also an example of how, in the absence of dignity therapy, as a therapist, you could have found yourself sort of feeling overwhelmed with sort of a sense of nihilism and hopelessness, like, what are we supposed to do with this kind of anguish? Well, I mean, I did not feel a sense of hopelessness or nihilistic. I felt really kind of empowered that we could be engaging in absolutely the thing that needed to be done, that she needed to do for herself and her family, and most importantly for her young daughter.
Well, and isn't that where the job satisfaction comes in? If you're talking about changing, the trajectory, here's the impact of this. We know what it can do for a patient, and we know what it can do for their surviving family members. But job satisfaction, to know that you were a part of facilitating this.
No, absolutely. And again, we might segue to the idea of intensive caring, but being able to feel equipped to be with suffering and to respond to suffering in a way that allows us to step away from feelings of hopelessness and impotence.
Yes, wonderful. So I do want to talk about intensive caring, and I want to talk about the platinum rule because that's one of my favorite things. So yeah, I've been saying this for years. So let's talk about the importance of intensive caring. Why is that term so important and that concept so important?
Well, I mean, I think it's important because, it sort of came out of, some of the thinking of Dame Cicely Saunders, who was the founder of the modern hospice movement. And she said, you matter because you are you, and you matter to the end of your life. And yet, when I looked at that, I thought, well and good, but where is the guidance to help us attend to people who feel like they no longer matter? People who feel helpless and hopeless and worthless. And that's where, I thought, well, if people are in dire straits medically or physically, we invoke intensive care. But if you're in dire straits psychologically or spiritually or existentially, then could we invoke intensive caring? And so that article was published a year or two ago in the Journal of Clinical Oncology, and it's being downloaded about 1,000 times a month, the last I checked. And it really tries to say, here are the core tenets of intensive caring. These are the ways in which you can be with patients who are suffering that will make you feel less hopeless and feel more empowered. And again, if we had sufficient time, we could go through each of those elements. And I would encourage your readers, and maybe in your, when you post this podcast, you can post the URL for the article. But looking at things, for example, like non-abandonment, engaging in issues related to personhood. There's also things about hope and how to contain hope and how to elicit hope, looking at the possibilities that are still available for people even towards the very end of life. And then there's a construct that I refer to as therapeutic humility. This idea that if you're going to be entering into an arena where fix is not always possible, therapeutic humility says that we let go of that, and we don't necessarily make that a mandate for our involvement with patients. And really, there are so many things that we engage with that are not fixable. And the paradigm of intensive caring really says it's a shift in medical paradigm. We go from, the usual traditional medical paradigm of examine, diagnose, fix. Intensive caring says, understanding the nature of somebody's suffering, non-abandonment, caring always. So that is sort of a gloss overview of and an introduction to intensive caring. But I think it's an interesting and important idea for palliative care because it allows us to enter into work where we know we can't always fix things, but if we show up, we can make profound differences for our patients and for their families. And if we show up with that kind of a mindset, then we don't feel like we're entering into imminent failure or entering into engaging in therapeutic nihilism. We really feel like we're engaging in meaningful work that can address patient suffering.
Well, when you think about the hospice philosophy as the care of the whole person, mind, body, spirit, and the connection between them that cannot be severed, how can you not address the intensive caring needs while you're still caring for the physical body? The focus may change as there's crisis in one area or another, but you can't affect one in a negative way without also affecting the other two in a negative way. And I mean, that's what hospice philosophy was built on, total pain, caring for the whole person. That's what Dame Cicely Saunders meant.
Exactly. And I'm not quite sure if we went through an era of becoming symptomatologists. We knew how to and became expert in dealing with various symptoms, but there are things that are more ephemeral and more difficult, so I mean, treating pain is one thing, but how do you treat somebody who feels like they have become a burden? How do you treat somebody who feels like they're no longer the person that they once were? I mean, those are much more difficult. They're much more nuanced kinds of constructs. Intensive caring allows you to enter into that space and understand that even in the absence of a pharmaceutical that is going to kind of turn that around, that your connection and the relational aspects of your engagement in and of itself begins to make a difference and begins to change that landscape.
Yes, and this is why we have interdisciplinary teams that include social workers, counselors, spiritual counselors. All of those people are so important. Absolutely. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
This episode is being sponsored by Care Boss, the latest book by Jennifer O'Brien. More than 54 million Americans are serving as unpaid caregivers for family members, friends, or neighbors with serious illnesses. Very few have received the training, guidance, or emotional support they need to succeed in this role. Care Boss, the newest book by healthcare leader Jennifer O'Brien, fills this need by identifying and empowering the family caregiver as the leadership position it is. Jennifer shares her motivation for writing Care Boss.
I wrote Care Boss because I have been a serial family caregiver and I have been a serial CEO in healthcare. And it occurred to me that the family caregiver position is indeed a leadership position. I would go so far as to say it is a leadership position of greater importance than the CEO of a Fortune 500 company because this is your person.
Jennifer writes with compassion and hard-earned wisdom. Readers will appreciate the empowerment and camaraderie they find in the pages of Care Boss. Care Boss is more than just a book. It's a workbook and organizer that enables family caregivers to lead their loved ones' care sensitively and effectively. You can find Care Boss at your local indie bookstore or on Amazon and at jenniferaobrien.com.
Okay, so now the platinum rule. The platinum rule. What is the platinum rule, and what does it mean for healthcare providers?
So, going back to, remember I told you that when we were studying dignity, we discovered that, the way that patients are seen has a profound influence on their clinical experience. So we began to take very seriously the way that healthcare providers see people. And intuitively, I mean, most healthcare providers see people through a lens that is shaped by the golden rule, which is, I look at something and I gauge how I would respond based on how I think I would want to be treated or how I would want somebody that I care about to be treated. And as I began to kind of look at that and think about that, realized that, that works relatively well if your lived experience aligns relatively closely or somewhat closely than the person that you're looking after. But what happens if the lived experience is very different? And that's where this idea of the golden rule, although still critically important, begins to break down, because we have to acknowledge that it still is imposing an external standard. And it also may be based on offering advice that we, the healthcare provider ourselves, would find untenable. So, what if I was that marginalized? What if I was that sick? What if I was that disenfranchised? What if I were that disabled? So we have to realize that all of us are socialized in a way that we see things in a particular way. We learn through experience, through exposure to media, that certain things are valued and certain things have less value. And so the Platinum Rule said, we need to be aware of our own biases and understand that the lens that we see someone through is tainted by our own life experience. So the Platinum Rule is doing unto patients as they would want done unto themselves. So seeing them the way they would want to be seen. And I have a couple of papers that I've published on it. One was in the Journal of Palliative Medicine, and one was in JAMA Neurology. The first paper actually was one that talked about a case of a gentleman who had a head and neck malignancy, and his medical oncologist one day sat down with him and said, things may get really difficult. And at some point, if things turn ugly, you may want to consider medical assistance in dying. Now, as it turns out, this man had no interest in that whatsoever. But the article then delves into what goes on in the mind of the healthcare provider. What is it that shapes that kind of recommendation? And again, what in introducing the Platinum Rule, you end up saying, well, the thing that likely shaped his recommendation is that he's offering information based on a personal perspective in which he thinks, geez, if I were going down that path, I know what I would be able to tolerate. I know what I wouldn't be able to tolerate. So that's where the Platinum Rule has kind of been introduced, or that's how it's been introduced. And it's been an interesting experience, actually, having authored that, because the uptake has been really quite extraordinary. About a year or 18 months after it came out, and again, bear in mind, I'm a psychiatrist who studies palliative care in Winnipeg, Canada. I would never have expected in my lifetime that Scientific American would reach out to me and say, we've heard something about this Platinum Rule, and we'd like to write a column on it. And indeed, Scientific American has written, and published a piece about the Platinum Rule, saying, this is now an important standard or an important way of raising the bar on person-centered care. And the other interesting thing about it is that it's not, even though I work, all of my research is almost exclusively in palliative care, things like the Platinum Rule, the importance of dignity, compassion, kindness, these things resonate across all of the human life cycle. And so the interesting about the Platinum Rule is that I see it applied, not just now in palliative care, but in all different arenas of clinical medicine.
I love the idea of this. So taking it specifically, taking the platinum rule specifically to end of life and death, a death.
Yep.
We talk a lot about a good death. But what I have found is that healthcare clinicians here in the U.S. assign a set of circumstances or a set of circumstances to what a good death should be based on what they consider a good death for themselves. It's their internal bias that they come to the experience with, and they project that onto patients and families.
Right. So here's a great example then of how to apply the platinum rule in an end-of-life experience. Very frequently, things unfold in a way that at some point in time, if conversations haven't taken place a priori, the physician will find him or herself in a room with a family member and say, well, what would you want done now? The person is no longer able to speak on their behalf. What do you think we should be doing? Well, what would you want us to do at this point in time? The platinum rule would say something quite different. The platinum rule would say, not to the patient, not to the mother or the father or the sibling at the bedside, what would you want us to do? What the platinum rule would say, if we could bring your father back into this room the way he was a month ago, the way he was 2 months ago. So if we could bring him back today and have him speak to us, not what is it you would want us to do right now, what is it that he would want? That's a platinum standard. That's saying that the perspective that we should be mindful of, the perspective that we should be valuing above all others, is the patient's. And so it's a really important way of bringing personhood back into that end-of-life scenario so that the right person, even though he or she can no longer speak on their behalf, the right person is actually making the decisions.
Yes. It's allowing that patient to still call the shots.
You got it.
Which is the way it should be, which is what any of us want. Any of us want. I get to decide what my good death looks like. You get to decide your goals of care, what your good death looks like. I love it. Platinum rule can be used all the way across the work that we're doing. I understand it can be used all across the healthcare continuum, but nowhere so important as end of life. So,
and I don't know. I know that it's the case in Canada that there's lots and lots of talk about EDI, equity, diversity, inclusiveness, and I imagine that it's no difference in the United States.
Yes.
It seems to me that the platinum rule is a critical foundation of any conversations about equity, diversity, inclusiveness. If we don't consider our own lens, if we don't consider our own perspective and the way that might taint or distort what we're seeing, I think we missed the boat on EDI.
Right. I agree. I think without an awareness of our own biases that we bring to our bedside care, there's such a risk of imposing our goals, our morals, our beliefs on the people we're taking care of. Absolutely. Dr. Chochinov, I wish we had more time to go on and on because there's so much to unpack and so much to talk about. How can my listeners connect with you, see the work that you're doing, access your articles and your resources?
Dignityandcare.ca is my website. I'm also the co-founder of a website called virtualhospice.ca. It's at this point it's the world's largest repository on information on end of life for patients, families, and healthcare providers. Information about palliative care, loss, and bereavement. And if people are interested, I'm on social media, on X at HM Chochinov or on LinkedIn, Harvey Max Chochinov. And those are all simply for professional purposes. I try and post articles and talks that I'm giving and, try and have most recent information available.
Awesome. I will have links in the show notes to both websites for Dignity and Care and for the Canadian Virtual Hospice and to your social media. Thank you so much for a wonderful conversation, for the wisdom that you've shared here. I know my listeners are going to get a lot of benefit from our conversation.
It's been my pleasure.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.